little bit, we noticed that the mechanistic insights around serum transthyretin levels were really interesting. So can you explain what you observed in this study with baseline TTR levels in variant versus wild type patients, the influence of acoramidis treatment, and why this matters biologically? Also, how did these biomarker changes impact functional outcomes and quality of life measures?
Yeah, so there's been a lot of the investigation the last year or two around serum TTR levels and their implications in these patients. We know that with transthyretin stabilizers, which acoramidis is one of them, that the levels of serum transthyretin tend to increase after starting treatment. And the thought there is that you're breaking down less of the protein, you're having stabilization of those tetramers, and so we see a rise in the serum level. Prior data that was published in the ATTRibute-CM study showed that for every milligram per deciliter increase in serum TTR after acoramidis treatment, that's associated with the reduction in cardiovascular hospitalization. So I think there's not direct causality, but it's a very helpful association as we think about advising or counseling our patients on what effect this treatment's having on their overall outcomes. We know that variant ATTR patients tend to start with lower baseline serum TTR levels compared to wild type patients, and probably has to do with these variant patients having a more unstable TTR tetramer, and that leads to more breakdown in the protein and thereby having a lower baseline level. But what we've seen in the ATTRibute-CM data is that with acoramidis treatment, both the variant ATTR and wild type ATTR patients have a rise in their serum TTR, and the rise in the variant ATTR patients is to a greater extent. So it ends up almost matching or similar, very similar to the levels of serum TTR for the wild type patients after acoramidis treatment. So even though they start at a lower serum TTR, they reach a plateau serum TTR level that's similar to the wild type patients.
The epidemiological implications here are staggering. Over 400,000 Black individuals in the US carry the V142I variant, with nearly 1 million projected lost life years. Given your findings showing such substantial benefit with acoramidis treatment, should we be doing something differently right now in clinical practice and in the level of public health to identify and treat these high-risk patients?
Yeah, I think it's important to highlight the disproportionate burden of morbidity and mortality among Black individuals when it comes to ATTR cardiomyopathy. And a lot of that is driven by the V142I variant. So, I think that these data from the subgroup analysis that we published show that there's a consistent benefit in this specific at-risk group compared with other variants of ATTR. From a public health standpoint, this comes to the larger picture of how do we screen and identify individuals with ATTR earlier, because we know that acoramidis as well as the other disease-modifying ATTR therapies work better with earlier stage disease. And so this is where I think uh, screening protocols through electronic health records, imaging studies, as well as just raising the general physician and healthcare community's awareness of ATTR is going to be really important to improve outcomes for not only Black patients, but across the spectrum of ATTR patients.